All right, how do you recognize respiratory distress in a newborn? First thing it lists is paradoxical chest movement. So, with paradoxical chest movement, this is a sign of severe distress. And the reason that you see the paradoxing is from airway obstruction. Or really stiff lungs. So airway obstruction or really stiff lungs. Sternal retractions occur in a newborn because there's all cartilage and not formed bones yet. So when they breathe in and they've got low lung compliance or airway obstruction, it'll pull the sternum into the chest. Rather than air going in, the sternum goes in. So you'll see sternal retractions. Nasal flaring is a sign of air hunger. This is the infant's effort to draw in more air through the nares. This is the infant's effort to draw in more air through the nares. Yeah, I don't know if it's just infants that have nasal flaring. I mean, we're the same way. You know, if we're breathing really heavy, our nostrils come out. I mean,
something that you don't notice though, it just happens.
Yeah, it's true, isn't it? You don't even think, okay, I need to flare my nostrils because I'm air hungry. Next is expiratory grunting, and this is the infant's attempt to increase PEEP in the lungs. Expiratory grunting is the infant's attempt to increase PEEP in the lungs. So they haven't even had a respiratory course, and they automatically know that PEEP helps. Yeah. And then a respiratory rate greater than 60 is a sign of tachypnea and respiratory distress. Why do I have a picture of head bobbing here? This just shows some other signs of respiratory distress. It's telling you when you have the ribs look like they're protruding. It's because this tissue is being pulled in during inspiration. So this is intercostal muscle retraction. Why do I have that picture there? Substernal retractions, again with respiratory distress. You see the soft tissue retracting in the substernal space. A little man.
That is some retraction. It's really bad.
Yes. So the abdomen comes out and the chest sinks in. All right, this is the Silverman scoring system that you have exam questions on your national exam, but nobody hears about it. Like if you ask the respiratory therapist in the NICU or PICU about Silverman Anderson scoring, they haven't heard of it. So you learn it for your exam and that's it, I guess. Let's see what the scoring would be. All right, so at the top, if you have synchronized breathing, where the chest and the abdomen go out at the same time, that's synchronized breathing. There's no retractions noted. The xiphoid process doesn't get pulled in. There's no flaring of the nares. There's no expiratory grunting. You would say that the Silverman scoring system would be a grade of 0. But if you see some lagging on inspiration, so you see a little bit of paradoxical movement, a little bit of retractions, minimal nasal flaring, and you hear grunting, but only when you listen with your stethoscope, you give them a grade of 1. But if they have marked respiratory distress, and you see the seesaw or the paradoxical breathing, you see the subcostal retractions, the sternal retractions, xiphoid retractions, marked nasal flaring, and you can hear the grunting, then you give the scoring of a grade 2. So they're in a lot of distress with a grade 2. Okay, I think that's it. Oh, respiratory distress.
Oh, wow. Is that the paradoxical breathing?
Yes.
That was cute.
Oh, that was fast. How do I go back? All right, so you see how the xiphoid process is being pulled in? And we don't really see the ribs coming out as much, but the paradoxical breathing is pretty obvious. Okay.
So it'd be grade 2. Would you classify that already?
Yes. And you see how fast the infant is breathing also? It's probably about, what, 80 per minute? That was pretty fast. So I'll tell you about, okay, one more, this is the last slide. Transillumination of the chest, and then we'll do the Dubowitz testing after your exam in 2 weeks. All right, so transillumination of the chest is actually putting a flashlight on the chest to see if there's air accumulating in the chest. So when there's normal tissue in the chest and you put a flashlight up to the infant's chest, you're not going to see the light illuminating a lot. But when there's a pneumothorax and the pleural cavity fills with air and you put that flashlight on there, the light shines brightly on the chest, and that's called transillumination. So to quickly diagnose a pneumothorax, a bright light is held up to the infant's chest. You place the light probe on the anterior chest, first on one side and then the other. So translucent is the word that you use to describe normal. And then hyperlucent indicates there's a pneumothorax. So a lot of air filling the pleural cavity, and the light will shine a lot brighter through the chest. So that's hyperlucent. So to say, oh, I think the infant's had a pneumothorax, let me order a chest x-ray. And then the x-ray department has to come, and they take the x-ray. And then they have to develop the x-ray, and then there's time. At least with transillumination, it's something that can be done very quickly if we suspect it. All right, so we'll end neonatal lecture now. And this is what will be on your exam.
Up until that point, right?
Up until that point.
Yes.
Or,